good now. Hey, good morning, everybody. Welcome back to the auditorium. Glad to have you all here with us. And we have a very special Grand Rounds this morning. Dr. Alexander Schafir is here with us to give us a Thieves Market Grand Rounds. And he's got a lot to cover and wants to get through. And so we're just going to jump right in. Dr. Schafir is a faculty at Providence St. Vincent, where he's been for 20 years. He graduated from Princeton University, the UCLA School of Medicine, and completed residency at the University of Washington. And he's presented the Thieves Market at ACP around the Northwest. And he's here today to give us a lively good time. So welcome, Dr. Schafir.
Thank you. Appreciate it. Thank you, thank you. I'll turn up my music a little bit, and then I'll turn it down a little bit. That's just to show that it's there. So can you all hear me now? Good, does that work? Great. Well, thank you very much. I appreciate the opportunity to be here today. I gave a Grand Rounds here some years ago on a totally different subject, and yet I got welcome back, perhaps because of bad memory, but I really do appreciate it. I was told that I was the first person. Stephanie told me that I was going to be the first speaker to get to use the new audiovisual system that was just installed, and she said this with great excitement, and I was thinking I must have felt like that astronaut who was thinking this is the first time we've used the space shuttle. But here we are. It seems to be all working great, so that's terrific. How many people have been to a Thieves Market before? Just raise your hands. Oh, great. Everybody's a newbie pretty much. So I'm going to have fun today. I'm certain of that. And I think you're going to have some fun today. You will have more fun if you try to win. So this is going to be a little bit different than our usual Thieves Markets. We have a lot of Grand Rounds nowadays, as opposed to when I was training. We have a lot of Grand Rounds that focus on our empathy, our caring for humanity, our deep commitment to service, which I believe can be completely in. This is not going to be like that today. This is about finding your inner nerd and helping to figure out what the diagnosis is. So let's get started here. Here are my learning objectives. How do my clinical decision-making on interesting and unusual cases compare with that of other internists? Can internal medicine really be this fun? And will I achieve instant fame and fortune by correctly diagnosing a case before it is presented on the screen? So I have some disclosures. I stole a lot of this from the internet, but mostly I stole from Dr. David Scrase, who's a professor of medicine and now the Secretary of Human Services in the state of New Mexico. But he has been doing Thieves Market at a national level at the ACP for about 20 years. And he's been helping to get me involved in doing this here. Here's how the cases work. I'm going to give you a presentation of the history and some key examination findings, basic lab and imaging studies, key tests, and a summary at the end of the diagnostic entity. You have a role, however, today. Here they are. You have to participate. You have to interrupt me frequently. You are the thieves, and you're going to try to steal the diagnosis before it hits the screen. If you do, you win. But you must say the exact diagnosis out loud, and I have to hear it and repeat it, okay? Now, I have a role here. I'm not going to lie to you. I'm not always going to tell you all of the facts right away. I'm not going to withhold any information if you ask. I'm going to tell you the truth if you ask me a direct question. I'm going to have fun. I know that. So I will give the winners also $1 million. I was hoping to be able to pay this out in Tubman $20 bills, but I couldn't find those. So I'm going to have to give you this $1 million if you win. And you're going to get your picture taken, and the winners have to come up if you win, if you get the diagnosis. Of course, if you yell out the right diagnosis, I'm not going to tell you right away if you get it right. We're going to let other people continue playing to embarrass themselves with other incorrect diagnoses. So the photo will be sent to Dr. Scrase at the Thieves Market International headquarters. Let's do a little bit of audience participation. So you should have one of these clickers here, and if you don't have one, just go get one. And if they're all run out, then just come earlier next year. So you need to turn it on, and there's a button on the bottom. There should be a blue light on the top. And so let's just practice now the audience participation. You're going to have to speak up so I can hear you if you want to win. So if I presented a case in which I said a 32-year-old spelunker who was recently bitten by a bat presented with, and I started, Rabies, exactly right. You've got exactly the thing. Now, exactly right. Now, we're going to have to hear that. So that's how this is going to go. You can only vote once, okay? And if you're wrong, no one's going to know. All right, so just keep voting. Decide quickly. You got about 10 seconds. Dr. Scray says you have to think like an orthopedic surgeon here, okay? And it's just like Tinder, okay? It's just like Tinder. Oh, I guess I should say in the Thieves Market, there are actually fewer cases of syphilis than in Tinder. But anyway, so there is a special message I have for anyone who attended the ACP meeting in the Oregon ACP meeting in Salem last November. This is the exact same presentation that I'm doing. So you should either leave now or you should claim CME credit twice for the same presentation. I don't really care. Should we get started? Yes. Okay, so now I'm going to present a case here of a 70-year-old man with a sore extremity. And it's not too early to be yelling out diagnoses, I just want to say. Gout, yeah, there you go. Okay, so he complains, so someone said gout. Could be the winner, right? Could be the winner. So, what was that? I didn't hear what you said. What's EVT? If I don't know, EVG. Oh, DVT. I also have bad hearing. That's good. If you say something I can't hear, you have to speak up. And if I say something that I don't understand, I don't know what it is, then it's not right. It's not the answer. Okay, so that's another clue. So this man has left lower extremity pain and swelling for a week. He has shooting pain that goes from his first toe up to the knee. It's intermittent and it lasts a few seconds. It woke him from sleep last night and it hurts to walk. Swelling makes it hard for him to put on a shoe. He says there was no particular trauma. His past history is notable for BPH and some memory loss, mild depression, hypertension, and sleep apnea. He smokes half a pack a day. What was that? Oh, thought I heard something. His father may have had a ruptured abdominal aneurysm. The patient has had a hernia repair and hemorrhoid surgery. He's married, is a CPA, he has 3 kids. He takes aspirin, citalopram, finasteride, and lisinopril. On physical exam, there's not much to look at of relevance here, but down when we get to the foot, we see that he has swelling of the midfoot. In fact, he has kind of point tenderness over the left first metatarsal shaft with a normal range of motion in the foot. The pain is not triggered with dorsiflexion or plantar flexion. There's no joint tenderness or effusions that we can tell, and the neurologic exam is intact. So at this point, now here's the audience response system. You're going to have about 10 seconds here. Why don't you tell me, at this point, I am this % sure of what is going on. Yeah, so we have several votes. Go ahead and just vote there. How sure are you that you think you know what the diagnosis is? Let's just see how people think that they're doing here. We'll see how far we get when this slows down. Yeah, you should be yelling out diagnoses, I suppose, but that's all right. So let's see. Well, we have some people who are 45%. We have some 3%. And then down on E, we have one person there who's 75% certain that they know what's going on. That's great. But would that person want to raise their hand and tell us what they think it is?
This isn't matching up.
It's not matching up. A, B, C, D. Well, okay. I apologize. Well, in any case, would the person who's 75% certain want to raise their hand? Who's confident they're not? Okay. So it's kind of a quiet confidence this person has about that. We see that in internists, though. That's okay. So here's another audience response system. We can start. Let me hide that, and we'll start over again here, if I can see this. Except now I can't see it. Forgive me for just a quick sec here. Where did it go? Excuse me a moment. Yeah. Okay, we might just be able to do it that way. Let's start the voting. Let's start the voting over. Go ahead. If you, at this point, what would you do? Would you order an X-ray, get a uric acid and a sed rate and a bone scan, order a lower extremity venous duplex, order an anti-CCP antibodies, HLA-B27 and a chest X-ray, or order leg rest and something funny on Amazon Prime, while the next patient is being roomed. Now, we see a lot of people would want an x-ray, okay, and that I think is fair enough. There it goes. So here are the x-rays. Now, this patient did in fact have an x-ray, and I'm going to want you to answer this question. These x-rays show a Lis-Ank fracture. These x-rays all have odd eponyms. A Charcot joint, a Chopard fracture, a Freiberg infraction. I suppose that's odd only because it's called an infraction. A Jones fracture, that's only odd if you say jaune fracture, I suppose. Anyway, or none of the above. And maybe we should review some of these. They're a little bit obscure. So here's an x-ray of a Lis-Ank fracture. A Lis-Ank is a tarsometatarsal injury, and there's a spectrum from sprain to dislocation to fracture. This is kind of hard to get. So it usually happens with trauma in males, maybe playing soccer, usually in the mid-30s. It's easily missed, and you can get complications down the road. Here's a Charcot joint. You're mostly going to be familiar with that, I think. And neuropathic arthropathy, progressive degenerative, it has progressive degeneration in a joint that doesn't have sensation. We know about that. This is a Freiberg's infraction. It's a rare and poorly understood phenomenon. It's essentially avascular necrosis of the metatarsal head, and it usually happens in the second toe and in the second decade, and usually to women. Here's a Jones fracture, tender lateral border of the forefoot typically, pain on weight bearing, resisted eversion. There's often antecedent pain in the setting of a stress fracture in this area, and it's infamous for non-union, right? Just like Walmart. And so 15 to 30%, there you go. So now let's go back to our, go ahead and vote here. What do you think this shows? Now, I have to say, there is no F on your little thing. So if you think it is F, none of the above, you can just raise your hand. That would be okay if you think none of the above is the correct answer. But go ahead and vote for which of these you think it might be. Lis-Ank, Charcot, Chopard, Freiberg, Jones fracture, or raise your hand. All right, let's see where we are here. So we have a number of people, and we can just demonstrate here. Yeah, a lot of people are going for E, a Jones fracture, although no one's yelled that out as the diagnosis. So you should be trying to win now, or you're not going to get the $1 million, because I don't think anyone has said Jones fracture. So here we go. Well, the x-ray showed none of the above. It was read out as normal. Let's get some more history for this man. He has no cough, shortness of breath, rash, or other musculoskeletal pain. He has no fever or malaise. He does remember standing on a narrow rung of a ladder and tripping over a wire, but he didn't notice any immediate pain or swelling at the time. Now, this would be a good time maybe for a public service message about ladders. People do use ladders in unusual ways. Over the years as an internist, I have come to think that many of my older patients shouldn't be using ladders at all, honestly. And so there are really safer choices to avoid. Here are some pictures of people who are avoiding using ladders, and might be safer to do that. I don't know. It's always good to have a spotter too, although I will say if he falls off the roof onto her, someone else is going to have to pick up their grandchild from preschool. So anyway, go ahead. Was there another guess? No. Metastatic prostate cancer from Bert. Hi, Bert. How are you? He's not a plant. We just go back. So he has left ankle swelling for a week. This is he went to see a podiatrist, and this is the podiatrist history. Left ankle swelling for a week. A little different than what the patient said. The pain started in the submetatarsal area, then the medial foot, and then the ankle. On exam, the podiatrist found a swollen ankle, tender anteriorly. There was a full range of motion. Dorsiflexion was a little weak, perhaps due to pain. There was normal light touch, power, and pulses. The podiatrist wrote that the history was the following, that the patient stumbled slightly on a ladder, but the history is more consistent with a gouty attack. And the plan for the podiatrist was to check blood work and a uric acid. If the blood work is normal, get an MRI of the ankle. Now, I think podiatrists, let's go back here to our audience response system, are good at relieving foot pain. We need some votes here. Order too many uric acids, like us. Must have a high prevalence of anosmia by self-selection, We're clever to avoid residency in internal medicine and orthopedic surgery, or all of the above. You can go ahead and vote any time now. Let's just see what people like here. Yeah. There it is, yes. So that's all of the above. Okay, well, I would probably agree with that. So the patient got an MRI, here's the answer. Now, you can just look at that for a long time, and perhaps you can get the diagnosis and win $1 million. That's what I would try to do if I were you. I find these a little bit difficult to read sometime, but I'm going to let you. I'm not sure that's an ankle. I don't know. Sometimes it blurs and it begins to look a little different after a while. So I think this MRI, there's a picture of it again. Let's go ahead and vote. I think this MRI shows the diagnosis, which concerns bone, and which you should be yelling out already here, or the diagnosis which concerns soft tissue. You can be voting now. It shows that the uric acid was completely normal. It shows a Schafir de la fluide par deux détachements. Or it shows why radiologists make more than we do, even though they have completed neither internal medicine nor orthopedics residencies. So let's go ahead and get some votes there and see what people think. And we'll just stop that and see where we are here. And there it is, yeah. Okay, well that's good. Let me hide that. So, this is a little reminder. This is a Picasso painting of someone studying for the boards. And so it's a reminder. We're going to have more Picasso coming. But this is a reminder that just for people who are studying for the boards, that Schafir de la fluide par deux détachements, that's never the answer on the boards. Okay? So I want to make that clear. Now, any last guesses then about the diagnosis here? Any last guesses? Morton's neuroma. There you go. Yeah. Well, it could be. I mean, Morton's neuroma, if they're really big, they can get up to the ankle, I suppose. I've never seen that, but there's no reason it couldn't. Any other last guesses? Anyone know who this is? Yeah, the residents wouldn't get this. Anyway, that's Janis Joplin. So, yeah, last guesses. Well, no one seems to have gotten this diagnosis, and that's okay. It's a little bit obscure. It's all about the MRI here. This patient had a rupture of the tibialis anterior tendon. And what we can see on the top is a normal patient, and on the bottom is our patient. These are actual images from the patient. And what you can see there is that we see at the very top there this nice black hole. That's what the normal tendon, anterior tibialis tendon, looks like on MRI. You can see a black stripe on the lateral view. But in our patient, you see this large area. It's enlarged, it's edematous, it's degenerative, and you can see over here, you can see that the black stripe is gone, and instead there's that inflammation going on. So he's had a retraction of the tendon to the inferior extensor retinaculum, which sort of explains his pain. This is a key case, however, of Osler. No, you can't have grand rounds without mentioning Osler. Listen to the patient because he's telling you the diagnosis. This patient's first complaint in the clinic was, the pain is shooting from my first toe up to my knee. That's what he said, and you know what? That is the origin and insertion of the tibialis anterior tendon. The tibialis anterior tendon is a strong dorsiflexor and inverter of the ankle, and the reason for that is that it inserts at the base there of the first metatarsal, and when it ruptures, you get a pseudotumor from the proximally migrated tendon stump, okay? And ankle dorsiflexion can still occur, but we're going to explain why in a second, but it's incomplete and it's weak. Here's actually a good picture. You can see that you get some ankle dorsiflexion, but when you do that, you get extension of the toes. Why is that happening? Well, that's happening because when you don't have your tibialis anterior tendon, in order to dorsiflex your foot, you need to use the extensor hallucis and extensor digitorum longus tendons, which get the toes as well. So you can see on the affected right foot in this picture, the toes go up, on the left, not so much. This leads to this triad of diagnosis, triad of presentation for this diagnosis. There's a mass, a pseudotumor in the anterior angle, extension of the toes with dorsiflexion, and also a steppage gait, because you can't dorsiflex so well. I'll try to demonstrate this. You get sort of a slapping gait because you you can't do that. So you're sort of, it's a little hard to do, but there you go. Anyway, and if I can do 2 feet, it would be something like this, almost like foot drop there. So that's what's going on. The risk factors for this are different for younger people and older people. In older people, it's, by the way, this is a really important concept for me that I had to learn, that everything I knew about orthopedics, no one had told me I need to make 2 categories, old and young, because everything in orthopedics is different between the old and young. And here's a good example of degenerative rupture in the elder versus traumatic in young people. This tendon degenerates in older people with diabetes, who use fluoroquinolones, who've had steroid injections before in that area, who have inflammatory arthritis, and who are weekend warriors in middle age. In youth, you can do this from dropping a knife on your ankle, or excuse me, on the top of your foot. From blunt trauma will do it, just dropping something heavy, and strong eccentric contraction, right? So eccentric contraction is a muscle that's working under load as it lengthens. So in this case, with tibialis anterior tendon, lengthening is that, and you can imagine running down a hill, for example, having to control how quickly your ankle flaps down, and so that is a way to get this injury when you're young. The differential diagnosis for this is a lumbar radiculopathy at L4. Of course, in that case, you're going to have an intact tendon. There's no anterior mass, and you're likely to have some dermatomal sensory changes. Common perineal neuropathy can look a little bit like this, but there's typically a history of compression of the nerve, and the toes are the extensor tendons are also affected, so you don't get that extension of the toes with dorsiflexion, and you probably have more profound foot drop in that setting. And of course, there's sensory change with a common perineal nerve. So the treatment is either operative or non-operative. That's a helpful heuristic. Everything in the universe is either operative or non-operative. Most things in the universe are non-operative, but there you go. So the patient, he came back 4 years later, about the time that I was writing up his case. He came back, and so I had good follow-up for this case. He had ignored our advice for surgery, and ignored our advice to get some alternative casting, and instead just went about his life. And he said, occasionally if I step on it, I hurt on top of the foot and the inside of my foot. Occasionally I trip on a curb, and I think I'm lifting my foot, but I'm not. It used to happen more, but now I'm used to it. That's what he said. Now, an interesting thing when he came back 4 years later is that he gave a very different history. Very interesting, about the exact same event. The original HPI, he said he'd had no specific trauma. He remembers standing on a narrow rung of a ladder. There wasn't any immediate pain. But what he told us on follow-up 4 years later was, I was standing on a ladder and I stepped backwards and I caught my foot. I remember that there was a limb in the way. I weighed 280 pounds and I had a chainsaw in my hand and the pain was excruciating. So I think, let's get some audience participation here. I think that the best explanation for this discrepancy in the history is that humans create useful narratives after the fact. The patient made up the chainsaw part later to sound macho. The doctor didn't hear it right the first time. The patient can tell the full truth about tripping while on the ladder with the chainsaw, only now that he's divorced from his wife and divorced from her disgust of his behavior. And the doctor heard it, but really, really wanted to order a uric acid. Go ahead and vote there. Let's just see what you guys might be thinking is the best reason here. And we'll just take a few votes. Yeah, humans create useful narratives after fact. Well, it's interesting that you kind of pick that one because there is some data about this. I went and looked into the literature about forgetting, fabricating, and telescoping. Here's an article from 2002, and they categorize fabrication, recomposition of the history, combining separate incidents into one, telescoping incidents, displacing past events forward in time or backward in time, which really mucks up your idea of what the frequency of the events are. And the causes of this in this article are posited to be personality, negative affect, state-dependent recall when people are shocked or in pain or anxious, the illness beliefs, the remoteness, the sensitivity of the subject, and the similarity of events. Here's a study about unusual histories in which 40 patients in an HMO could recall only 41% of their visits in the last 12 months. More interestingly, 28% incidence of false recall of visits that had never occurred. So we know this. Here's a study about denial and confirmatory search. Very interesting. Subjects in this study were educated about a fictitious enzyme deficiency, and then they received a fictitious test for this and told the fictitious results. Subjects who were informed that they were positive for the fictitious disease then recalled more behaviors that had been labeled as risk factors when they were educated and reported that they had had more symptoms of the disease and not of other symptoms. So here's a comparison of recall and daily self-report of fecal incontinence. This is a geriatric study in which patients reported by history fecal incontinence, and this is a very selected elderly population, of bowel incontinence of about 1/2 per day, but then they recorded it in a journal, and it was 3 times that amount. Interestingly enough, and sadly enough, if you were a care provider of one of these folks in this study, this effect was even more. The care providers had fecal incontinence, which they were hiding even more than the patients themselves. So it tells us something about our folks. It does make you wonder, though, what else this patient might have left out in the history to give him this injury. So that's the end, and I think we're going to have to move on to another case. So let's see who can win this time. I have a 71-year-old woman who has an abnormal mammogram. It's not too early to yell out breast cancer. No takers. That would be obvious, wouldn't it? Okay, well, that's fine. The patient called to follow up on an annual surveillance mammogram ordered by her oncologist. I told you we'd have more Picasso. This is woman getting a mammogram. Picasso, 1936. Now, the radiologist said that the left breast, here was the report that we received, in fact, that the patient received before we did. The left breast demonstrates diffuse skin thickening that appears more dramatic when compared with all of the prior studies since the lumpectomy. This is suspicious. An MRI of the breasts is recommended. No takers.
Radiation dermatitis.
Radiation dermatitis. Okay, yeah, good. Other thoughts? What's that? Paget's disease of the breast, okay. The patient reports that the left breast has been abnormal for 10 years since her first lumpectomy. She reports that she has a firm lump near the incision site with no recent change. She denies any pain, redness, nipple discharge, skin, or shape changes. She has no fevers, chills, or weight loss. She has a history of bipolar disorder with psychotic features. She has orofacial dyskinesia. She had a history of a PE unprovoked 12 years ago, and then 2 years later, an unprovoked DVT, so she's on warfarin for life. She has a fine chronic tremor. She has osteopenia. Her past medical history is also notable for breast cancer, diagnosed 5 years ago, stage 1, ER/PR positive. She had a lumpectomy, radiation, and Lotrozole. She has type 2 diabetes. She has stage 4 kidney disease of unclear etiology, and she's planning dialysis. And she has vitamin D deficiency. She had a sinus surgery 20 years ago. She had a DNC for endometrial hyperplasia a long time ago. She's had cataract surgery. She had a lumpectomy that was benign, and then 5 years ago, a lumpectomy that was positive, where she also had a sentinel lymph node biopsy. And she had a fistula creation for dialysis about 2 months prior. She's on a mess of medicines that I'll just let you look at here. And you can be thinking of what you might be causing this abnormal mammogram.
There's a warfarin breast thing.
There's a warfarin breast thing. Okay, warfarin breast thing. We'll note that in the log. It could be. It could be. So she lives in a group home due to disabling bipolar disorder. She doesn't use tobacco or alcohol. She doesn't exercise. Her family medical history is unknown. So on exam, she has normal vitals. There's no lymphadenopathy in the neck. Her lungs are clear. Her heart is unremarkable. The right breast is normal, but on the left breast, there is thickened skin, 8 to 10 centimeters around the nipple. There's no peau d'orange. There's no erythema, no nipple retraction, warmth, or tenderness. She has a well-healed incision in the left upper quadrant of the breast with a 1 centimeter hard mobile mass medial to the scar. She has an appropriate mood and full affect. She's fully oriented despite her psychiatric illness. I do have a picture of the patient, or a patient. It's not actually the actual patient, but it's another Picasso, but you can see actually that the breast here is enlarged. This is the Dreamer, Picasso, 1932. This is a lot of what this patient looked like. Her lab tests were unremarkable except for a BUN of 58 and a creatinine of 3. Her INR was 2.3 in the therapeutic range. So at this point, let's go ahead and get a vote here. Let's just see. Go ahead and vote when you want. At this point, I am this % sure of what's going on. Get an idea here of where people think that they are. What is her calcium level? That's a great question, and I don't know is the answer, which means it was unremarkable. It was. Keloid as a diagnosis. There we go. So a lot of people have no idea what's going on. We have some people have got some ideas, and we've heard some ideas here. Again, we have someone again who's 75% certain. Does that person want to raise their hand? Who's 75% confident? No, again, that's that quiet confidence again. That's okay. That's all right. We don't mind. We don't mind. So here are the mammograms, just to convince you that something is going on in this patient, perhaps, at least according to the radiologist. In the prior year mammogram is up top, and the current mammogram is below, and I think even non-radiologists can see some changes here. So audience response system again. At this point, what would you do? Order an MRI of the breast, order a biopsy of the breast, refer urgently to a breast surgeon, review the films with the radiologist if it's between 9 a.m. and 4 p.m., or wonder if Picasso also painted the mammogram. That would be reasonable questions. Let's go ahead and get some votes here, and let's see. All right, we'll stop that. Yeah, okay, well, we've got a lot of people want an MRI. Some people want to just go ahead and get a biopsy, and that sounds reasonable. A couple other people want to talk with the radiologist, and one person is interested in Picasso. Okay, well, there are two, because I'm interested in Picasso too. Anyway, as it happens, Picasso did paint the mammogram. Here it is. Here's a picture of it. You can see there's a good match there. Just by chance, this is the Mirror, 1932. It's a detail. So the here's the mammogram report. Skin, because I didn't give you all the information. The full mammogram report is that the skin thickening that appears more dramatic as compared to all prior. This is suspicious for inflammatory breast cancer, is actually what the radiologist said. And they recommended an MRI to evaluate for abnormal hypervascularity, the activity of inflammatory breast cancer. There's an awful lot of words there. This made me, sort of think that the mammogram, this is, to paraphrase, the evidence we have obtained about the patient in the mammogram presents difficult issues that would need to be resolved if we were making a traditional medical diagnosis. But at the same time, if we had confidence after a thorough investigation of the facts that the patient clearly did not have inflammatory breast cancer, we would so state. Based on the facts and the applicable medical standards, we are unable to reach that judgment, and accordingly, while this report does not conclude that the tissue is malignant, it does not exonerate it. That's kind of what I took away from the report. It sounds a little bit to me like the Mueller report. I don't know if there's some plagiarism going on here. I don't know if this is legal, but there we go. I'm not going to read through all that. But this here, by the way, is the Mueller report in black and white if you haven't seen it, because we all should be looking at it. So now it's hard. It can be hard to find the radiologist sometimes, but we have great radiologists. I found, however, that there is. You should know about AlertView. That is a product made by Novarad. It's called AlertView App, and it makes it easy. This is an actual advertisement, and it really helped us to find the radiologists, okay? So we were able, an actual advertisement here, so, and we were able to talk to the radiologist. The radiologist reviewed this and was perplexed by the absence of symptoms. So certain was he that this patient might have inflammatory breast cancer, and he emphasized that the mammogram was suspicious. But he revised his recommendation. He thought, you know what, let's do a biopsy to definitively rule out cancer rather than doing an MRI. So some of you voted for a biopsy rather than the MRI. Let's remind ourselves about inflammatory breast cancer here. It's a disease in which there are tumor emboli within dermal lymph vessels, and it gives the appearance of erythema and edema, right? There are diagnostic criteria from a joint committee on cancer, which suggests that all of the following criteria have to be met, none of which our patient meets. Rapid onset of breast erythema, edema, or peau d'orange in a warm breast with or without underlying palpable mass. Duration of no more than 6 months. Our patient has lots of changes in her breast, which she reports have been there for 10 years. She has erythema, there needs to be erythema in at least 1/3 of the breast, and pathologic confirmation of invasive carcinoma. So this made us all concerned. Now that we had a radiologist telling us an MRI, no wait, not an MRI, let's get a biopsy, we did some more thinking about it, and we became concerned about a diamond-shaped algorithm. We were thinking that if the biopsy were positive, she would need to see a surgeon. If the biopsy were negative, she would need to see a surgeon. If she got an MRI and it was positive, she would need to see a surgeon, and if the MRI were negative, she would need to see a surgeon. So we really couldn't, we thought maybe she should just see a surgeon. This is a diamond-shaped algorithm. We didn't really like either of those plans very much. We thought we would simply refer her to a surgeon. Now I learned, I was reminded about diamond-shaped algorithms in a different setting, in the setting of how you use ANAs and other serologic markers in rheumatologic disease from our wonderful teacher, Richie Wernick. Yeah, so diamond-shaped algorithm. So we did get a surgery consultation, and the surgeon found this on exam. There's a 3-centimeter mass suggestive of fat necrosis. There is dependent edema in the breast of 8 centimeters centered around the nipple. There's no redness, peau d'orange, or adenopathy. And the surgeon's plan was to review with the radiologist. Okay. So we didn't know if we could find the same radiologist. You know, how's that going to work out? Thanks to AlertView, we were able to find the second radiologist who reviewed all of the films once again and suggested that we get a breast ultrasound. So here is the breast ultrasound. It demonstrated a palpable lump that corresponds to an inhomogeneous mixed hypoechoic lesion, likely fat necrosis. There's no mention of breast edema. And the surgeon's new plan was to ask radiologist number 3 about the breast edema, because that was the major finding on exam that was potentially new, and the ultrasound didn't say anything about it. So here's a question for you. I can name this many causes of unilateral breast edema. All right, because this would be the time to be yelling them out. More than 10? Go ahead and take a vote. 6, 8, 3, I can name, I'm about to learn of some, like you have no idea. You can't think of a single cause. Maybe 2. If the patient has anasarca but had a mastectomy before, then maybe they'd have unilateral breast edema. And syphilis, because you got to add syphilis to the differential diagnosis of everything, right? Dr. Gilbert, am I right? Pretty much everything. Thank you. Thank you, yeah. So let's just take some votes here, and we see D. I'm apparently about to learn of some, yeah. Okay, well, that's fine. So let's review some of those. There are many, but mastitis can give you thickened skin, and axillary lymphadenopathy on mammogram, and you can see these changes on ultrasound. Morphia is sort of localized scleroderma, is how I think about it. And this is a disease that may be associated with radiation therapy to the breast, silicone breast implants, trauma, and I suppose morphia occurs out of the blue, and I suppose it can occur out of the breast out of the blue too. Marty, is that right? Morphia of the breast just could happen like anywhere else? That's right. So metastases, it can give you unilateral breast swelling and edema. This is an example of signet cell stomach cancer with mets to the breast. Primary breast lymphoma is a relatively rare disorder, but it occurs. It's a terrible disease, in part because it's often diagnosed very late. And CHF, well, more commonly, here's a paper, case report. Our patient was lying predominantly on the right side, which accounted for the right unilateral breast edema. But they managed to get a little case report out of it. They did another one the next year for left breast edema, I think. They just turned the patient over. That is, publish or perish. And then here's the superior vena cava syndrome can do this too. There's edema, peau d'orange of the right breast. And in this case, lung cancer was compressing the vena cava and occluding the right subclavian vein. Angioedema can occur anywhere on the body, including the breast, and that's been described on one side. There's a disease called granulomatous mastitis, a terrible kind of deforming disease, also diagnosed late because it's so rare. I'd not heard of it before doing research for this. So let's do a little bit of voting here. The 2 most unusual aspects of this case so far are What do you think? An abnormal mammogram and a history of breast cancer, a history of thromboembolism, and treatment with Lotrozole. Abnormal breast exam without any symptoms, treatment with warfarin and skin abnormalities, no diagnoses there, and 2 radiologists and the prospect of a third. Let's see, what are people thinking here? All right, well, let's just look there. All right, so we have some people who are thinking about the warfarin and skin abnormalities. Anybody want to say more about that? Because you might win, you know. Yeah. What's that? Oh, gosh, no, it's on the tip of her tongue. It's not on the tip. Now, here's the thing. If it's even on the tip of your tongue, you should yell it out. On the other hand, if I'm trying to coax it out of you, it's probably not the answer, okay? That's just the case. So let's see here. Radiologist number 3. How's this going to work? Another radiologist, yes. Let's see, it did work. We were able to find the 3rd radiologist. And this radiologist, actually, the 3rd radiologist actually suggested another test, okay? Suggested another test. And this made me aware and alarmed me, reminded me about the diamond-shaped radiology algorithm, which is that whether you see 1, 2, or 3 radiologists, if your test is negative, they'll suggest another imaging test, and if the test is positive, they will suggest another imaging test. Okay, so this is another tool. Here is actually this is a reminder, Picasso reminding us about diamond-shaped algorithms. This is Au Lapin Agile, which is translates as the radiology reading room. So now, a diagnostic test was performed in this case. Let's go ahead and vote on this. And I think it was a CT angiogram, a PET scan, a biopsy, consultation with a vascular surgeon, but you can only reach them between the hours of 3:30 a.m. in the morning and midnight the next, that late that night. Those are the only hours. And then whatever test radiologist number 3 suggested, even though we told the radiologist that that test had already been done. So let's see what we get here. So people like the idea of a biopsy. Okay, well, that's perhaps a reasonable thing to start with. So behind that, any last guesses now as to the diagnosis here? Anyone know who this is? Stephen Colbert. Stephen Colbert. Okay, so any last guesses about the diagnosis here? Hi, Andy. Nice to see you. I know it's late, but it's okay. You've seen this before. I go way back with Andy, so it's okay. A recommended test. Well, this was the recommended test by the 3rd radiologist. Why don't you do a graft duplex? And we said to the radiologist, well, we already did one. 1 month before the mammogram, the patient had a widely patent brachiobacillic fistula with normal velocities. Now, but we repeated the duplex. And this time, the duplex showed patent left brachiobacillic fistula with 2 areas of stenoses, one that was proximal to the anastomosis and one that was at the bacillic axillary confluence. So the diagnosis here was unilateral breast edema from AV fistula stenosis. Remember, she'd had this placed about 2 months prior to this mammogram or so. So let's do a little voting here. I think the normal range of graft systolic velocity is 1.5 to 3 meters per minute, 100 to 400 centimeters per second, often misunderestimated, easily discoverable on the internet or fake news. What do you know about graft systolic velocity? Because it was on the previous slide there. Let's just see here what people think. There it is. Yeah, it's kind of all over the place. All right, well, that's kind of, it's 100 to 400 centimeters per second for future. Next time your vascular surgeon sends you one of these studies, you'll be able to peek at it there. So what's a brachiobacillic fistula? Well, this is a fistula in which when they use a very deep vein, the bacillic vein, it requires a big surgery. You have to fillet open the arm and then connect it up to the brachial artery. But what this gives you is you end up with a very long superficial area for access, okay? And that's what happened. There are other cases of unilateral breast edema from similar diagnoses. Here's unilateral breast enlargement secondary to a brachiocephalic vein inclusion. The woman on the right side here had central venous stenosis causing unilateral breast edema. She needed a mastectomy for treatment of that. Here is angioplasty of our patient, and that's how we fixed this patient. So I gave a lot of grief here to the radiologist, but I want to say it was radiologists who made the diagnosis in this case and radiologists who fixed this woman for us. We fixed it, and that's what happened. Here is Picasso Nuée avec fistule occluse. The patient refused dialysis. She actually, when I made this slide, she was living. She actually passed recently from uremia, decided she didn't want to have dialysis and decided to pass. So there she is. All right, well, let's move on to our last case. We need a winner now, so let's see what you can do. You need to be yelling out more, taking more risks. It's okay. Well, because she decided that later, which is in the nature of humanity and perhaps more in the nature of humanity with severe bipolar disorder. So she was certain at one point that she was going to have it and then decided against it. A woman with lower abdominal cramps. Yeah, you could be yelling out anything you want at this point if you want to win. What's that? What was that? ALS. ALS. Okay. I suppose. I'm probably not in on this joke. There's probably a joke that I'm not in on, but it wouldn't be the first time. So she has intermittent sharp lower abdominal pain and cramps for a month. She's not doubled over. In fact, she's still able to do her golfing. She has cramps, though, that last hours. She's up all night with lower abdominal cramps, but she was up all last night with lower abdominal cramps, but now she feels fine. She also complains of some tightness in the epigastrium, bilateral costovertebral angle pain, and chest pain that's lasting some minutes, she says. So a lot of different symptoms. These symptoms have no relation to exertions, bowel movements, or eating. She had 3 BMs today, which is normal for her. She has no fevers or chills, anorexia, shortness of breath, edema, melena, hematochezia. And the illness was not obvious to her spouse. He notes that she's still been able to continue golfing. Whoops, daisies. So her past medical history is notable for tubular adenomas 3 years prior in the colon. She has palpitations, history of atypical chest pain. She has severe seborrhea of the ear canals, and in fact, 1 month ago was treated with ciprofloxacin for epitigenized, I practiced this multiple times, epitigenized otitis. 10 years prior, she had a bout of abdominal pain, and she got a CT scan that was, quote, strongly suggestive of intra-abdominal mass, perhaps lymphoma. So I arranged a CT-guided, this was 10 years before this presentation, I arranged for a CT-guided biopsy, and then when they went to do that, the scouting images on CT showed no mass. And it turned out that the original findings had been an artifact of uninflated bowel, a well-known artifact of CT, which they now have mostly done away with, but scary episode for the patient. Her abdominal pain 10 years ago went away. She has no tobacco, drinks 1 glass of wine a week. Exercise involves mostly golf. She has a son who had melanoma. She has a history of a hysterectomy, total knee replacement, carpal tunnel release, and she takes multivitamins, magnesium, probiotics, vitamin D, and krill oil. On physical exam, her blood pressures were, her vitals were normal, and I forgot to put them in on this slide. She appeared a little anxious, but her head, lungs, and heart were unremarkable. In fact, in the belly, she had no tenderness or distension. There were bowel tones, there were no abnormal masses, and no CVAT. Looked pretty good on exam. So she had a CMP and a CBC. She also had a lipase at this time, which was normal.
What's their last colonoscopy like?
Roughly 3 years ago, and they found a few polyps.
Diverticulosis?
No. So let's say at this point I'm this % sure of what's going on. You know the drill here, but you should be, there's a broad differential here. You're not going to win $1 million unless you start yelling out some ideas here. So instead of asking me about the colonoscopy, you could just yell out, colon cancer. You could do that. I mean, that's not the diagnosis here, but you could do that. So let's see what we've got. Yeah, you never know. So, all right, 0%, maybe the difference. Some people, 25%. Okay, well, let's keep going. So a week later, she calls back and she says that her symptoms are changing. The diarrhea, she says, is now worse. And you think to yourself, what diarrhea? She didn't actually mention diarrhea last time. She has loose stools 5 times a day. She's lost 4 pounds. She still doesn't have fever, nausea, vomiting, melena, or hematochezia. It takes her, for whatever reason, a month to get into clinic after this phone call, and now she's had cramps present for 2 months. It wraps around the upper abdomen, the right ribs, and the flanks. It hurts to roll onto her side, and sometimes it wakes her up at night. But she now reports that the diarrhea has been present since the very beginning of this whole thing, and her exam is normal, except that she's lost 10 pounds in the last 2 months. Giardia, celiac disease, I heard. What else? What's that? C. diff. Krill oil.
Something mechanical, adhesions, partially obstructing, volvulus, internal hernia.
You can keep going, Dr. Gilbert. You can keep going. That's okay. There we go. So at this point, I would do what? Let's get some votes here. I would order C. diff tests and x-rays of the abdomen. I just wrote C. diff tests because at this point in my life, after hearing several lectures, including at the National ACP meeting, I have no idea what C. diff test to order anymore. So I would order a right upper quadrant ultrasound. I would order a CT scan of the abdomen, since that went so well 10 years ago. I would stop her krill oil and magnesium and refer her to GI, or I would go back and add complaining of diarrhea to the original clinic note. Okay, well, let's see here what people want to say. Give them a chance. I'll stop this. And okay, there we go. All right, yeah, kind of a mix. People like the idea of getting a CT. So we'll see. Now, 2 people wrote add complaints of diarrhea to the original clinic note. Okay. You know that that's, unethical and maybe illegal. You know that, don't you? Okay, I just want to make it clear. So, all right. Now, here, she ended up getting an ultrasound as her first test. Here's a picture of the ultrasound. And I took a 2-day bedside ultrasound course at the National ACP meeting. It was fabulous. It was an amazing course. And after that, I can tell you with great confidence that this is an ultrasound image. I'm certain of that. There it is. Well, this image shows that she has a normal liver, spleen, gallbladder, aorta, and IVC. There's no fluid. She has a normal common bile duct, normal for her age at 7.7 millimeters. She had some kidney cysts up to 4.5 centimeters, but no stones. She has some simple liver cysts. In the pancreas, there was a focal mass-like lesion up to 6.1 centimeters in the head and neck and proximal body, heterogeneous and hypoechoic. Yelling out diagnoses here. Here's your CT scan. Is that going to tell you the diagnosis? How are we doing? Well, her CT scan, here's what it was read out. Bilateral, non-obstructing nephrolithiasis, not seen on the ultrasound, up to 7 millimeters. Mild dilatation of the pancreatic duct. The pancreas enhances homogeneously. There's a small cystic lesion at the pancreatic head without enhancement, and for this they recommend MRI or CT in a year to follow up. You can't be very worried if you're recommending a whole year. I don't know. Anyway. There's no lymphoma. The patient and I were both released. She and I were the only ones who remembered about this false positive CT that she'd had years ago, but there was no lymphoma. So I think the 2 most unusual aspects of this case so far are, let's go ahead and get some voting here, flank pain and non-obstructing kidney stones, mass in the head of the pancreas and abdominal pain, diarrhea and the use of krill oil, broad spectrum antibiotics and diarrhea, persistent GI symptoms without GI procedures so far. Okay. All right, well, let's see what we're getting here. All right, people are up on the GI symptoms, and some people are worried about the mass in the head of the pancreas. Any ideas what that might be, though? We're not really getting anything. I don't know why there weren't procedures yet so far. It's been a long case of abdominal pain. Maybe it had something to do with the presence of gastrogulf, so I found this as an actual advertisement. Maybe that's where all the gastroenterologists were. I don't know. But she did eventually end up with an endoscopic ultrasound. And there it is. I sometimes find these difficult to read, but there it is. You can decide if there's anything you can see there that's useful for you. Here's what they said that it showed. There were several small polyps in the gastric body, a normal bile duct and gallbladder. The pancreas had some lobularity. There was atrophy, stranding, and a cyst in the head of the pancreas not communicating with the duct. They suggested a follow-up MRI in 1 year and an ultrasound in 2 years. That sounds like job security to me, but anyway, most of my patients don't live 2 years. I just want to admit that right now. So, left adrenal gland was normal. So on further history, the patient returns after her ultrasound and says now she has pain all the time. It's low intensity. It's still radiating to the right flank. It's hard to lie on her right side. Diarrhea has improved after treatment by the gastroenterologist. the patient, the spouse, and the gastroenterologist, they're all still able to golf. Probably Dr. Gilbert's able to golf. I don't know, maybe so, could still do that. So let's talk about some rare causes of abdominal pain when the extensive workup is negative, because you guys, you're a little afraid to say pancreatic cancer. You're thinking this is something rare. Let's review some of these maybe. How about mesenteric venous thrombosis causing indolent pain? This is a disease caused by a hypercoagulable states, such as myelodysplastic syndromes. Abdominal surgery, inflammation in the retroperitoneum. And you treat it with anticoagulation, thrombectomy, or surgery. Another rare cause of abdominal pain is paroxysmal nocturnal hemoglobinuria. Very rare. It's an abnormality in a gene causing reduced activity of these proteins. That's also the way you make the diagnosis nowadays. Clinically, you're looking for abdominal pain that's associated with microangiopathic hemolytic anemia. We might consider acute intermittent porphyria, right? Has this cool, one of the best words in medicine, neurovisceral symptoms with abdominal pain and psychiatric disturbances. You see port wine urine in severe cases. It's precipitated sometimes, these attacks, by menstruation or fasting, barbiturates, tobacco, and other things. It's caused by a partial deficiency of porphobilinogen, deaminase, and you make the diagnosis with a 24-hour urine porphyrin test. You treat it supportively and with IV heme. You know, they're now making synthetic heme in labs to make magic burgers, right? Meat, and I wonder if they're going to be able to use this for porphyria. Somebody should, but you can have it. You can publish it. Go ahead. All right, new treatment for porphyria is the fake hamburger. Okay, rare causes of abdominal pain when the extensive workup is negative. Familial Mediterranean fever could be patients with Mediterranean descent. They have recurrent fever, abdominal pain, serositis. They sometimes have AA amyloidosis, and you make diagnosis with genetic testing. But our patient was not considered any of these diagnoses. None of that was considered, but she did undergo, per the gastroenterologist, a carbohydrate breath test. So I want to ask you now, I think the carbohydrate breath test, I'm going to go a little bit late. I'm going to try to move up here, but we're going to zip through this. So I apologize. If you need to leave, please do. It's used to diagnose Helicobacter pylori infection. It's used to diagnose small bowel intestinal bacterial overgrowth. It's used to diagnose the Otto-Brewer syndrome, lactose intolerance, or the carbohydrate breath test is the reason I lost my driver's license. Which of you are going to vote here for what happens? Let's see, we've got some votes. Let's just see what people think. Yeah, a lot of people are using it. Yeah, small intestine bacterial overgrowth. In the interest of time, I'm going to leave you to the others here. SIBO is a colonization of the small bowel by excessive microbes normally present in the colon, presenting with bloating, flatulence, abdominal discomfort, watery diarrhea. Steatorrhea is rare unless there's a blind loop. It can be complicated, it can have complications, and you sometimes see it, it can be confused with Crohn's disease, irritable bowel syndrome, celiac disease. It's associated, what causes this, what are the associations? Well, small bowel stasis, so small bowel diverticuli can give you bacterial overgrowth. Strictures, blind loops, Dr. Gilbert was talking about some kind of mechanical obstruction there. Hypomotility. In the gut can predispose. Diabetes, scleroderma, radiation therapy, Crohn's disease. A fistula between the small bowel and the colon so that the colonic bacteria get right into the small bowel directly. And there are other associations, cirrhosis, alcoholism, etc. The carbohydrate breath test works in the following way. You give people lactose and glucose, which are normally metabolized by the colonic bacteria into hydrogen and methane. That's normally excreted in the breath. It takes about 2 to 3 hours to do this. If you have SIBO, however, you have an early peak in the excretion because these sugars are metabolized in the small bowel early. This test requires careful preparation. There are lots of false positives. It's compared, the gold standard is a jejunal aspirate looking for high bacterial concentration of the small bowel, but that requires an EGD, and the results are poorly reproducible. The treatment is typically metronidazole first, and in this study, that's 44% effective. Rifaximin is a little more effective. But even UpToDate says, look, patients with no improvement after 2 courses of antibiotics should be evaluated for alternative diagnoses. Our patient had a positive test. and was treated with metronidazole, 500 milligrams for TID for 10 days. This increased her abdominal pamps and diarrhea, similar to the onset of her disease by her account. She had some more testing, including negative fecal white blood cells, stool culture, and giardia. She was then treated with rifaximin for 10 days. A diagnostic test was performed. What do you guys think it was? I think it was C. diff toxin and gene assays, small bowel biopsy, response to rifaximin, culture of the jejunal aspirate, and a test already presented that, unbeknownst to me, had given away the diagnosis, but we missed it. Let's see what people think here. Any last guesses? There you go, Sarah Jessica Parker. That's worth $10, not $10 million, not $1 million. But that's okay, that's Sarah Jessica Parker. Here was the diagnostic test, my friends. Here is her CT from a year ago and her MRI now. The diagnosis is staring at you. Actually, it's not staring at you, it's not there. Because the problem is that a year ago she had a pancreas. And now, whoops, excuse me, and now she has no pancreas. So the diagnosis in this case was chronic pancreatitis. That was the diagnosis for her, possibly complicated by small intestinal bacterial overgrowth. She didn't respond to therapy, so she might never have had that disease, or it might have simply been ineffective. We don't really know. But chronic pancreatitis is manifested, you have dilated pancreatic duct, often with stones in the duct, and an atrophied pancreas. You see fibrosis and a mononuclear infiltrate. Chronic pancreatitis symptoms include abdominal pain and pancreatic insufficiency. The pain is episodic at first, but becomes continuous, just like our patient. And the pain may be absent in some patients have no pain at all. The diagnostic criteria are really complicated. Don't read that thing on the right. Those are the complicated diagnostic criteria. Not a lot of agreement. But a CT scan with atrophy and intraductal calcifications is probably very predictive. The symptoms are non-specific and late. Amylase and lipase are usually normal. EUS endoscopic ultrasound is increasingly being used. Our patient had 4 of the 6 things that are thought to suggest this diagnosis on endoscopic ultrasound. She had cysts, lobularity, irregular dilated pancreatic duct, and hyperechoic foci and stranding. This requires a highly skilled gastroenterologist who can golf. Now, the etiology, if you care to listen, is often alcohol, but when it's not alcohol, it's usually idiopathic. But there are genetic causes like cystic fibrosis. Ductal obstruction can give you chronic pancreatitis from any cause. Systemic diseases like lupus, hypertriglyceridemia, and hyperparathyroidism are thought to be related. There's something called autoimmune pancreatitis. There's tropical pancreatitis. I don't know what that is. I suspect this man has it. The treatment is to stop smoking. Sometimes you even have to remove the pancreas, or excuse me, sometimes there is hydration of small meals, celiac nerve blocks, lithotripsy, XRT, and resection of any remaining pancreas are sometimes used to treat the pain. It's complicated by SIBO, right, sometimes. Vitamin deficiencies, and also a false diagnosis of alcoholism. I certainly strongly considered that possibility in this patient whose husband was a big drinker. She was a regular drinker, but at modest amounts, and I wondered all along in this case whether we just weren't picking it up. After all, the two often go together, golfing and drinking. The risk of pancreatic cancer for this disease is very high. I'll go through this kind of quickly here, but the incidence ratio is 26%. The hazard ratio is 7 compared to other patients. So is this a thing? A little talk here about ontology, a little guideline, even though we're late. Ontology is the study of being, of basic categories. So is this a thing? It's a syndrome. A syndrome is a constellation of signs and symptoms, and in pathology, syndromes are proposals for new diseases, right? They're sort of applicants for new diseases. And they're fanciful and they're useless unless they're helpful in the realms of etiology, prognosis, and treatment. Non-A, non-B hepatitis, if you remember, raise your hand quickly if you remember non-A, non-B hepatitis. Yeah, a few of us do. It was a great syndrome. It really helped us to treat all of those patients, to understand that they were acting as if they had an infectious disease. And then we discovered hepatitis C, which explained most of the cases of patients who had previously been diagnosed with non-A, non-B hepatitis. A great syndrome. Mild cognitive impairment, plus minus, right? It helps us give a label. It helps us with prognosis. It doesn't help us so much with treatment or etiology. When I hear mixed connective tissue disease, I want to look at the rheumatologist and say, hey, buddy, your ontology is unzipped. Like, is that really a thing? I mean, seriously. Really? And I think about left otitis media. I like to call that otitis of Schafir. That's a syndrome that is not caught on. Turns out to be totally useless, but there you go. And so for chronic pancreatitis, what do we have? Well, the etiology is suspiciously varied and often idiopathic. The diagnosis is suspiciously complex and controversial. The prognosis is a little bit circular. You have to have pancreatic failure for the diagnosis, but you have to have pancreatic failure, but that predicts the diagnosis predicts pancreatic failure, and the treatment is suspiciously supportive. So is it a thing, right? Is it a thing is the question. It's a constellation of pain, exocrine insufficiency, duct dilation with stones, atrophy, and a high risk of pancreatic cancer. Is that useful? Well, I can tell you this. The gastroenterologist, before the endoscopic ultrasound, prescribed pancreatic enzymes that fixed the patient's diarrhea because she recognized symptoms consistent with pancreatic insufficiency. She recognized the pattern of stubborn abdominal pain and diarrhea over time. She also had a CT scan that had been somewhat abnormal. So Ursa Major it's a random circle around a bunch of stars. That constellation doesn't exist. It's an artifact of our position relative to the stars on Earth, and from anywhere else in the universe, it's meaningless to talk about that constellation. But you know what? You can use it to find the North Star, and that's maybe where this syndrome is helpful. Susan Sontag said, an idea which is a distortion may have a greater intellectual thrust than the truth. It may better serve the needs of the spirit, which vary. I'm all done now. If you can go ahead and vote. Having heard this, I now understand that ontology concerns philosophy, ontology recapitulates phylogeny, etc. Listen, we're just going to stop. We don't really need to vote on that. I want to thank you all for your participation today. I'm sorry we had no winners, but you're all winners for putting up with me. And this is, getting in touch with your inner nerd. If you have a case for me, contact me. Please do that. We can write it up together. It requires maybe a couple hours of work for you. I'll send you a template, and you don't have to fill in any of the academic parts, or you can fill in all of those. You don't have to fill in any of the funny parts, or I can fill in all of those, but let's do it together. So all you have to do is contact me, because I need more cases if we're going to keep doing this. And if you ever go to the National ACP meeting, please see Dr. Scrays. More Picassos. I don't know that I have more Picassos here today to show you. I wish I did. Thanks.
Thank you. You put a lot of effort in it. It showed.